I'm Monique Rainford, an obstetrician and gynecologist, an assistant professor at a large academic institution. I've been in OBGYN for more than 20 years. I've spent about half that time in private practice and half that time serving federally qualified health centers.
Each year, over 14,000 women are diagnosed with cervical cancer in the United States alone, and approximately 4,000 women will die from the disease. The pandemic has changed the dynamic by increasing the burden of cervical disease. A recent study in the Journal of the American Medical Association showed double-digit declines in cervical cancer diagnosis throughout the first year of COVID-19. Decreases in newly identified cervical cancer cases suggest that there are women with undiagnosed malignancies, some of which may reflect advanced stages as a result of deferred care.
The pandemic has definitely impacted the timing of that people seek care, and sometimes with actual dire consequences. They come in for care and it's later than you'd hope, and sometimes later than would provide hope, depending on the condition. There was a study in JAMA that showed that during the pandemic, there was a double-digit decline in cervical cancer diagnosis. So what does that mean for long-term health outcome? It means that at some point, these people will come in with cervical cancer. The problem is they'll come in with cervical cancer later. And the truth about any cancer, the later it's diagnosed, the worse the prognosis. The less options there are for treatment, the less opportunity for survival and beating the cancer, so to speak. So the pandemic had an adverse effect on people coming in for a diagnosis, and it's very likely will have an adverse effect on the life and longevity of people who come in with a cancer diagnosis. And so it's a vicious cycle. And when they come in for care, they come in later for care. That could mean that if they have the disease has more time to progress and leaving less options for intervention. As such, you may need to give them the screening that optimizes your chances of detecting disease, as you would with anyone who's at higher risk. I believe that co-testing gives you the opportunity to optimize your ability to detect disease, that disease being high-grade dysplasia or cervical cancer. When a patient comes in for a visit, I do co-testing. I want to ensure that I find out anything that I need to find out at that visit so that I can make the best diagnosis based on that one visit to decide how to take care of them in the future. I like co-testing for that reason, because it gives us both pap smear results and high-risk HPV results. Enough research has shown that co-testing picks up more cervical cancer diagnosis, or CIN3, cervical high-grade dysplasia. Co-testing is when pap and HPV are ordered together, processed together, and the results are reported together. A Quest study published in the American Journal of Clinical Pathology that was released in 2020 showed that co-testing with pap and HPV was more likely to diagnose cervical cancer and precancer than either pap smear alone or HPV testing alone. HPV testing alone fails to diagnose 1 in 5 women with cancer within 12 months of diagnosis. That gives me the best information I need to determine if they have any precancerous changes or frankly cancer, or the best information I need to reassure them that everything is fine and I don't have to rescreen them for a few years. I do feel that I have a responsibility, and I try to do as much as possible I can, even if the time is short. When you read the rationale for U.S. Preventive Services Task Force guidelines, you recognize that there are certain populations that are higher risk for cervical cancer, or they're either more likely to be diagnosed with cervical cancer, or they're more likely to die from a cervical cancer diagnosis. FQHCs take care of a lot of high-risk patients. So what do I mean when I talk about high-risk patients? They are high risk because sometimes they're under-screened. They can be high risk by the very fact that they don't speak English. If you come into a FQHC, often it's because you can't get care anywhere else, or you haven't been getting care anywhere else. And if you don't have access to care, you may come in a little later for a condition that would be less risky if you sought care earlier. In that population, I want to do the tests that are most likely to diagnose the conditions for these patients, because I know that they're probably presenting later for care. I know that they probably don't have as much routine screening as someone who is more affluent or belongs to another community. So when they come in, I want to make sure that I find anything there is to find when they come in, so that I can take care of it as quickly as possible to get the very best outcome for them.
Not only co-testing more efficacious in detecting cervical cancer, but is actually more cost effective when you think about not just the upfront cost, but when you think about the procedures a woman would have to have after in terms of colposcopies. When we think of the treatment she would have to have if diagnosed with cancer and follow-up. Based on everything we have, all the information we have, co-testing seems a better option in every way for women in terms of both cost effectiveness and quality of life and lives saved. We see that overall it is a very cost-effective option. We've clearly seen with LARCs, long-acting reversible contraception, that while the upfront cost of a LARC is higher than the cost of an oral contraceptive pill, the overall costs are much lower for LARC compared with an oral contraceptive pill. We know that in terms of adherence. We know that in terms of unwanted, unintended pregnancies. We know that in terms of continual use of these methods and how long these methods last. So we do have real examples where sometimes the upfront cost of a product may be higher, but the overall benefits, the overall efficacy, the overall cost are actually much lower. And we don't have to look very far in the future to see that benefit. We do have examples of that in clinical practice. The bottom line is that the cost of treating precancer and cancer far outweigh the cost of screening with co-testing, not to mention the benefit to women and women's lives.
When I do cervical cancer screening on my patients, I follow ACOG guidelines, which is consistent with U.S. Preventive Services Task Force guidelines. To meet the HEDIS measures, we do have to follow the task force guidelines. That gives 3 options in the 30 to 64 age group: PAP only every 3 years, HPV primary every 5 years, or co-testing with PAP and HPV testing every 5 years. For the population, we take care of FQHC, which is a very heterogeneous population. The test that gives them the highest likelihood of being diagnosed with cancer if they have it, or pre-cancer if they have it, is co-testing with PAP and HPV. And that's why I do believe that that is the best test for the population of women that's cared for in FQHC settings.